for joining us this morning, which I hope will be a useful session for you all. And I hope you've all had now time to digest the various bits of information and guidance that have been shared, and obviously had time to think about implementation within your school settings. Um, just to let you know, we are recording this session to make it available for colleagues that are unable to join us. And obviously, Louise will be doing her usual presentation just to give you an overview of the current situation in Havering, and that will be made available as well afterwards. Similar to previous sessions, colleagues, if you can utilise the chat function to post any comments or questions as we work our way through the presentation, and we'll make sure that we've got time at the end for a sort of general discussion and Q&A session as well, if that's helpful. And obviously, if there's anything particular comes up, that will help inform further guidance, notes or advice that we set out. So it's excellent to have so many of you here with us this morning. So if we get started, then it'll be a bit of a double act, as always, colleagues, between myself and Louise, who you all know very well now from our public health team. And she's got a brief-ish presentation to take us through, just a bit of general information and updates, but also obviously a focus on the plans and preparations for the full opening from the 8th of March. So colleagues, I'll just introduce Louise, although I think she needs no introduction to many of you. So Louise, did you want to share your screen, hopefully?
Thanks, morning all. Hopefully this will come up okay. Can everybody see that okay? I can't see any nods. Trevor, is it? Yeah, lovely.
Fine, yeah, thank you.
So, wow, here we are, 8th of March, eh? That's a really good place to be. I don't know about you, but my kids are so excited about going back. I think they just can't wait to be back in the school environment again. But I know that the challenges that that's going to pose for you all as head teachers is phenomenal. So we will do our best within public health and education to support you as much as possible through these challenging times. So we continue to work together. So this morning, I'm just going to take you through a little bit of update on the COVID data, where we are at the moment with the current case rates, looking at the rates amongst different age groups as well. Just going to briefly cover some aspects of vaccination and again where we are with the current uptake rates. Briefly go over the public health elements of the return to school plans, and then talk about the lateral flow testing for staff and pupils within different settings. And then we'll open up for general discussion and questions. I've tried to pick up from some of the things that we covered yesterday morning as well. So for example, face visors versus face masks. So we'll cover those as we go through, but I'll try and answer as many questions as I can. So where we are currently, and oh my goodness, the last time that we were together, I looked back at my notes and our rates then, which I think was in January, was 1,225 per 100,000. Our case rates now, as of the 17th of February, are 90.9 per 100,000. What a phenomenal difference. So it's really good to see that the lockdown has had its desired effect, and we are now much lower on our case rates, which is fantastic. If we look at the number of residents testing positive each week, we had a massive peak around December, January time, and we're now down to, by the 5th of February, by the 12th of February, it was 302 cases testing positive in 1 week. So we are much lower rates, which is fantastic. The positivity rate has also gone down a lot as well. We're still slightly higher than London and England in terms of our positivity rates, but we're looking at around about a 9% positivity rate. We really want that prevalence level to go down even further. So the lower the positivity rate, the easier it is to manage with the contact tracing. So that's what we really want to move towards, is really effective contact tracing where we stamp out any positive cases. And that's where the lateral flow test devices are really going to come into their own to identify those who are asymptomatic, isolate them and stamp out the infection so that we can prevent any subsequent waves. excuse me, a subsequent wave is still possible with all the new variants that we've got coming into the country. But if we follow the release guidance as much as possible and maintain all those social distancing, then we have a chance of stamping out any subsequent waves. Excuse me. Looking at the weekly incidence rates amongst different age groups, we can see over the December period, the 11 to 16-year-olds, the grey line at the top here, had a very large peak of the incident rate of over 2,000 per 100,000. And that's the 11 to 16-year-olds. There's been a bit of coming and going, but the 0 to 4s and 5 to 10s stayed relatively low. And we're all down now at a very low case rate for all ages, which is good. So that's the incidence rate. If we look at the positivity rate by age group, this is a percentage positivity rate. At the moment, the 5 to 10-year-olds have the highest positivity rate. It doesn't necessarily mean that there's more cases amongst those groups. So when we look at the previous slide, we can see the incidence rate, the number of cases that are actually happening. The 5 to 10s are right down there low. But what they're saying is when a person is tested, it's most likely that in those 5 to 10-year-old age groups, it's because they're symptomatic when they're being tested. So the positivity rate is likely to be higher. So it's not that they're having more cases, it's that it is more likely that for those that are being tested, they're being tested because they're symptomatic or, showing signs, or it's happened in the family. So they're positive because of the transmission within that family, not necessarily that there's a higher case rate amongst those particular age groups. I hope that makes sense to everybody. If we look at the number of people that have taken tests over the last few weeks from the 1st of January, the grey lines, or the grey bars here, are the number of people who've had a PCR test, and the blue line is the number of people who've had the lateral flow device test in the previous 7 days. We can see that the proportions are changing between the PCR test and the lateral flow test. So we're having an awful lot more who are taking the lateral flow tests, which is really good. So the number of tests have actually stayed relatively stable over the last few weeks. It's a slight decrease now, but with the lateral flow tests coming back into schools, we're going to see an increase in those numbers. And the guidance from the government is really test, test, test. The more that we can test, the more that we can identify those, particularly asymptomatic people, and say get them out and stop that transmission within the school environment. So we can see that with the positives falling, the number of PCR tests that are being taken, which is only if you've got symptoms, that's been reducing, but it's been replaced by asymptomatic testing, the lateral flow tests. So just because our case rates are falling at the moment, doesn't mean that we should stop testing. In fact, it's even more reason to keep testing now so that we can keep on top of any subsequent outbreaks. So I thought that would be an interesting one to show, to say the relative proportions of the PCR versus the LFT test. So for vaccination, we mentioned this yesterday briefly, but the priority group for vaccinations determined by the Joint Committee on Vaccination and Immunisation, the JCVI, they looked at the evidence for who's been most directly affected by the virus, and they prioritise according to the impact on death rates. So the highest number of those deaths have been amongst those over 80 years. So the highest priority group to receive those vaccinations are the over 80s, followed by those who care for those particular age groups as well. It places a really high priority on promoting rapid, high levels of vaccine uptake amongst those vulnerable groups. The Pfizer-BioNTech vaccine was used in the very first phase of the programme, and that's the one that had to be stored at really, really low temperatures and then defrosted and used. So that had to be stored between -80 and -60 degrees C, and then once it was thawed out, it needed to be used within 6 hours. I think that's being taken over now by the Oxford AstraZeneca vaccine, which is much easier to manage logistically, and that can be stored in a fridge between 2 and 8 degrees C. Both vaccines have been shown to be effective, and they've been approved for use in the UK. whichever vaccine the cohort had in the first round is the one that they should receive in the second round. So while a 2-dose schedule is advised, at the moment there's some really good evidence, as we heard on Monday evening with the presentation from Chris Whitty, there's evidence to indicate that there's really good short-term protection from a single dose. So while they are focusing at the moment is on the first dose is being given to as many people as possible before the second dose is given to those first recipients. And they said whichever vaccine is given, the second dose must be the same vaccine as the first dose. But there's no preference for which vaccine to use amongst a specific age group. So whichever one you had, it's absolutely fine and it offers a reasonable protection. And it's shown that even the first dose is having a good level of protection. So the priority group order, these are the different cohorts 1 to 9. And it corresponds with the data of the number of people who would need to be vaccinated to prevent one death. So those resident in a care home for older adults and their carers were cohort 1, all those over 80 years of age, and frontline health and social care workers were cohort 2. And we can see it goes down in 5-year age bands according to the number of deaths that would be prevented. What I find a little sad here is it doesn't actually explain where teachers come into this. Are they health and social care workers? What priority group are they in? I would like to have seen personally a little bit more clearer evidence and clearer guidance there on where we fit into this. But at the moment, it's really very much based on clinical risk and age. At the moment, we're working on cohorts 5 and towards cohort 6. So at the moment, we're at cohort 5. If we look at our uptake rates across East London, London and England, those were vaccinated with the first dose by the 7th of February across East London was 73%. Actually, in Havering, we're now up at 94% of those over 80. Sorry, of those aged 75 to 79. We've got 94% of those aged 75 to 79 have received their first dose of vaccination, which I think is a really good uptake. And overall, we are at 32% of the entire eligible population in Havering have received their first dose. So we're getting quite good coverage already. This will be shared with you as well, so you can have a look at these percentage uptake rates later yourselves. Excuse me. So the summary of the key public health guidance for the reopening. I'm just going to run through very briefly the key 12 points, which is about minimising contact of individuals who require to self-isolate. So basically, it's about maintaining that system of infection prevention and control. Face coverings, I'm going to talk about those a little bit more later, but it's about ensuring face coverings are used in recommended circumstances. Washing hands more thoroughly. You know all this already. It's just that reminder. So, I'm not teaching my grandmother to suck eggs, so to speak, but it's just that reminder of these are the main systems of infection prevention and control. Ensuring good respiratory hygiene, so promoting the catch it, bin it, kill it approach. Coughing, sneezing into the crook of an elbow. Obviously, if you've got a face covering on, that's much better. Washing those face coverings regularly as well to make sure that they're kept clean, particularly where people have maybe coughed or sneezed because you can't get the tissue under the mask quick enough. Maintaining enhanced cleaning in the school environment, making sure we clean those frequently touched surfaces, using standard products and detergents. Considering how to minimise contact across the site to maintain social distancing wherever possible. Keeping occupied spaces well ventilated. Something to consider there is in terms of ventilation, the children may need to wear more layers of clothing if there's going to be windows open. The school environment itself might be a bit colder. And it's absolutely fine. There is no additional need to wash clothes differently. You don't have to clean them more frequently as well. It's just a matter of keeping regular, normal hygiene procedures and practices. Keeping those occupied spaces well ventilated, either through air conditioning approaches, but if it's got access to outside ventilation, that is far better to keep those aerosols moving and away from people as much as possible. We mentioned very briefly about the face coverings. The guidance actually says that face visors or shields should not be worn as an alternative to a face covering. So, although they protect against droplet spread in specific circumstances, they're unlikely to be effective in the aerosol transmission because the sides are open, basically. So, if you're doing close contact work with somebody, you might need a face shield as well as a face mask. So, the shield can help prevent those droplets that are coming either from the person to you or you to the person you're working with. But the aerosol transmission and actually stopping the virus going as much as possible whilst you're speaking, whilst you're talking loudly in assembly. Obviously, the louder you talk, the more droplets you have coming out. So the face mask needs to cover the nose and the mouth effectively. You can wear the face shield as well as a face mask, but that would only be needed in certain circumstances and if you were having situations where you needed full PPE to be worn. So, for example, with somebody who is positive for COVID but needs some close-up care in some way. So the recommendation there is definitely the face mask. And if you do choose to have a face shield or visor, it's as well as a mask, not instead of. So it's recommended that they should only be used after carrying out a risk assessment for the specific situation, and they should always be cleaned appropriately. So as I say, that situation might be where you have a positive COVID child who needs the more close-up care. In terms of having face coverings, the recommendation is now for face coverings to be worn in secondary school pupils as well as staff, and that's in the classroom as well as going around the school, unless social distancing can be maintained. So it'll be up to you to make a judgment within your school environment of how many children are there within the classroom. And I would say recommend wherever possible to wear a face mask, even within the classroom environment. The teacher, if they can keep social distancing, may not need to because obviously there are communication issues. So we have to make sure that the face covering doesn't interfere with the teaching itself. But the more opportunity you have to wear the face mask, the better it would be. It was recommended in the guidance to have a small contingency supply of face masks who available for people who are perhaps struggling to access a face covering. So that might be for children who are eligible for free school meals. This might be something that could be within the lateral flow test kits when they arrive. I believe that there were some small amounts of PPE that were orderable within that system. So I am hoping that through that DFE system of resupply of kit and the LFT tests, you should be able to order some PPE face masks, which could be kept as your contingency supply. We'll look into that further, and obviously if you've got any questions, you can come back to us on that one. If anybody has any trouble accessing contingency supply of face coverings, let us know, and then we'll see if we can work together to find an alternative solution. So the face masks, the contingency supply would be for those perhaps who are on lower incomes, those who are eligible for free school meals. So we don't want people to be disadvantaged in any way if they can't access a face covering. It seems unlikely, but we don't want to disadvantage anybody. So people who are unable to use their face covering as it's become damp, soiled, unsafe, or people who've forgotten their face covering. We know what kids are like, they forget things. But no pupil should be denied education on the grounds that they're not wearing that face covering. So the last systems of key public health guidance is about maintaining that system of infection prevention and control, ensuring individuals wear appropriate PPE where it's necessary. So remember that difference between PPE and a face covering. A face covering is used under normal circumstances. PPE would only be necessary where you've got somebody who is perhaps positive for COVID and that they need additional protection whilst you're working with that positive person. And it's promote and engaging in the asymptomatic testing wherever available. I'm going to come on to talk about that very briefly. In terms of responding to any infection, it's about engaging with the NHS testing process as per normal procedures that we're all used to now, managing and reporting those confirmed cases of coronavirus amongst the school community, and contain any outbreaks following local health protection team advice. So we're there for that advice, and locally, as we've been providing already, there might be a slight increase as we come back to school in terms of the number of positive cases, particularly in the first couple of weeks where we're doing more testing. But remember, that's good to find those positive cases because it's about isolating them and making sure that they are kept off. If the children are well, even if they're positive, if they're asymptomatic positive, are well, they're still able to engage in remote learning. If they are isolating because another family member is positive, again, they can still engage in the remote learning. There's no excuse not to engage in that learning. Sorry. Okay, so onto the testing. This is a really good summary of the testing that is recommended within different settings. So in private nurseries, in PVIs, private nursery environments, the DfE are now going to provide home test kits, so home lateral flow test kits for the private nursery workforce, as well as the nurseries in maintained school environments. So this is really good news for those PVI providers as well. That's going to be twice weekly testing. Primary school pupils do not need to test. Primary school staff should continue to do that twice weekly home testing with the lateral flow kits. Secondary school pupils will be doing 4 tests on their return in the first 2 weeks. 3 of those tests need to be within the established asymptomatic testing sites. So that's what ATS stands for here. So the asymptomatic testing sites that were due to set up in January, I'm sure many of you have been implementing that over the last few weeks anyway. So this is because it's actually set up as a test site itself. So your school becomes a registered test site. The school on return of the pupils will need to do 3 tests in those first 2 weeks for each pupil and 1 test at home within those first 2 weeks, 3 to 5 days apart. So there's a difference here between saying I need to do 3 tests in the first couple of weeks or 4 tests. The 4 tests is basically relating to 3 in the school environment, 1 at home, 3 to 5 days of work apart. And then after that point, it's twice weekly testing at home for secondary school and further education pupils. For secondary and further education staff, it's twice weekly testing at home. So the difference there is instead of having to do it within the school environment under the asymptomatic testing site, the secondary staff are going to move to the same as primary staff and be testing at home, which I think is far more convenient for everybody. A lot of places have been doing a regular schedule of a Sunday night and a Wednesday night, which seems quite a reasonable approach for the days of testing. Obviously, how you set up that yourselves is quite important. The recommendation is 3 to 5 days apart to allow for that twice weekly testing. In further education, it's twice weekly home testing for older students in colleges. And then it says testing by demand for independent and adult providers. I'm not sure what that really means, so I'm going to look into this about what they really mean by testing on demand and get back to you on that one. Within children's social care, introducing testing for new placements and visitors to secure and open children's homes, and twice weekly testing for the workforce who work in children's social care. So that includes anybody within social care will be coming to visit your schools as well. And for higher education, it's about continuing twice weekly testing on site for all staff and students. So I've just put together a little timeline here to show what's going to happen basically from the 8th of March. So from the 8th of March, primary school staff will continue to do that twice weekly testing at home, 3 to 5 days apart, recording the results via NHS Test and Trace online or by phone. The instructions for that are actually on the LFT test kits themselves, but also to inform the school of the result of their tests. So that's going to carry on from the 8th of March all the way through to the end of the spring term. We're not clear yet on whether that testing needs to continue through the Easter holidays, so we'll establish that and get back to you with more clarity. For secondary schools, for staff, the twice weekly testing from the 8th of March can be done at home. Again, 3 to 5 days apart, recording that results via the NHS Test and Trace and informing the school of the result. Then within the first couple of weeks, secondary school pupils are to test 3 times on site and once at home within the first 2 weeks, 3 to 5 days apart, recording the results as normal via NHS Test and Trace online or by phone and informing the school of the result. So this is where there's some flexibility for head teachers as well, that the return to school could be on a phased basis. So that can be considered to enable you to allow for that testing of the 3 times for those secondary pupils. We know there's an awful lot of pupils to get through, and there's a lot of discussion that needs to be had about how we can practically implement that as well. I'm sure you've all got your own methodologies of how to do that within your school environment. And if you'd like to have a discussion over your particular methodology, please feel free to contact me or Trevor and we will help support you through it. Vulnerable children and children of critical workers and year groups 10 to 13 should be prioritised according to the guidance. So in terms of thinking which groups to come back first, it will be the years 10 to 13 first. After the 22nd of March, so from those first 2 weeks, the secondary pupils will then continue to test twice weekly at home using their lateral flow test kits with adult supervision to take the test and recording the results. And it says that testing should become part of the normal routine. So they recommend the taking the test the same days each week. So again, a Sunday night and a Wednesday evening might be the best approach, but it's completely up to you as a school of what works best for you in terms of getting the right number of tests in that week, but also making sure you're recording the results and looking at the potential impact of positive cases on the impact on the bubbles themselves. Just here at the bottom, in terms of the ages of who can test themselves, who can self-swab, pupils aged 18 and over can self-test and they can self-report the results. So the 18 and above, the adults, they can do everything for themselves. Pupils aged 12 to 17 can self-swab, they can self-test, and they can report the result with adult supervision, whether that's in school or at home. So the adult supervision there means just somebody checking up on them and making sure that they're doing it right. The amount of adult supervision is obviously going to be dependent on what parents can do at home. And it's recommended that it's adult supervision, but basically 12 to 17, they can do most of it themselves. It's just making sure they've got an adult to check on them. For the 11-year-olds, pupils aged 11, there's a couple of bits of guidance here. They can self-test with adult supervision. So what they mean here is that those aged 11 can do the swabbing themselves of their throat and the nose. A nasal and throat swab is the most effective type of swab, but we also acknowledge that not everybody would be able to or is comfortable doing the throat swab particularly. So if it is not possible to do a throat and a nose swab, then an alternative is to do a double nasal swab, so in each nostril. So the most effective is the throat and nose. If that's not possible, then double nasal swab is absolutely fine to do. So those aged 11 should have the test, well, it's recommended to have the test administered by an adult. So where an adult can do it, that is the best approach. In the clinical SOP for secondary schools at the moment, so the clinical standard operating procedure, it does say in there that pupils aged 11 can also do the swabbing themselves under adult supervision. So there's some flexibility there if you want the 11-year-olds to do the swabbing themselves, or if you prefer to have an adult administer the swab. So there's some flexibility about which one you choose to do, which model you choose to do. The results should be reported by an adult, though, amongst those age 11, so the year 7 age group. I hope that's quite clear for everybody. Just a few notes on testing itself. Just a reminder that testing is voluntary. No child can be refused access to education if they choose not to test. All we can do there is recommend, support and encourage as many people to test as possible, because the benefits of testing are clear in terms of identifying and isolating those positive cases. There's around about 1 in 3 who are asymptomatic, so people who are not showing any symptoms at all, who could be potentially spreading the virus to others. So the more that we engage in the regular testing, particularly through these lateral flow devices, which are quick, convenient and quite easy, that's a really good step forward. So self-swabbing or administered swabbing may cause concerns for children and young people with special educational needs. So it's thinking differently about what might be more effective for those particular children, or whether it is appropriate to do so for those children. As I say, you can do the double nasal swab instead of the throat and the nose swab if that actually is more acceptable to children with different needs. For consent, only needs to be sought once for testing, whether that's at school or at home. So for pupils who already have been in school because they're children, vulnerable children or children of critical workers, if you've already sought consent to do testing, which they might have done within the first weeks of coming back, you don't need to re-ask for consent. So consent only needs to be given once. So pupils who haven't been engaged in that process already, we need to follow those consent forms that are in the guidance packs that are in the resources documents on Google Drive. So that consent needs to be sought, but it's sought once, whether they do it at school or at home. We don't need to keep asking for consent. The daily testing of contacts of positive cases, which was suggested originally in the guidance documents, which was going to be once a day for 7 days, that continues to be paused. So we're not doing daily contact testing at the moment. However, something to consider is in the first 2 weeks of school, in the secondary school pupils, having a secondary school set up as an asymptomatic testing site, an ATS, the recommendation is that a small scale ATS is kept on site in secondary schools following those first 2 weeks for anybody in the secondary school who cannot or is unwilling or has challenges in actually testing at home. But that would be hopefully far, far fewer pupils that would need to do that. So it's about maintaining a small ATS on site for anybody that does need additional support or supervision to do and engage that testing process. If you've been vaccinated already, and that's very possible as we're moving in towards the clinically vulnerable groups now, so staff who have been vaccinated should still engage in testing. This is because no vaccine is ever 100% effective. So we still need to test, and it is possible that even if you've been vaccinated, if you've been exposed to the virus could be circulating in your body. So although you are not going to get it yourself, you could still be a carrier of the virus. So it's important to still engage in testing, even if you've been vaccinated. However, if you've had a positive PCR or LFD test in the last 90 days, you do not need to take part in the twice weekly testing. So anybody that has had COVID, a positive COVID test in the last 90 days, does not need to engage in the testing process. Okay, so the rationale for doing this, I mentioned about 1 in 3 often being asymptomatic, so there's no symptoms, so we don't know. Secondary school pupils can transmit at the same rate as adults. Amongst primary pupils, there is insufficient evidence to prioritise testing, so we don't need to do primary school pupils. And repeat testing is likely to be unpleasant, particularly amongst the younger age groups, so they're not doing the repeat testing. And amongst early years staff, we've now got parity with other educational settings, which is good. So the 3 tests at the asymptomatic testing site on return will familiarise the secondary school pupils with the test process. They'll have more supervision with the ATS, so they'll learn how to do it for themselves at home. And it will help minimise the number of incorrect results because they've had that supervision in the first place once they take on the home testing themselves. But then once they take on the home testing, it's going to minimise the disruption in school. So it'll allow people to test before they enter the school. However, it is acknowledged that testing at home might decrease the test performance if they don't do it properly. So the more advice and support that can be given, particularly to secondary school pupils in those first couple of weeks, to help learn how to swab as effectively as possible, that will help maintain the test performance as we go down the line. But if somebody is finding it difficult at home or does need extra support, or you find that they're getting inconclusive test results, it might be better to call that person into the small ATS on site to give them that additional support and perhaps a booster or a refresher about how to do it. So if you are getting people getting more inconclusive test results or having to do 2-3 times to get a result, then call them into the ATS, offer them that additional support, and then send them back home again with tests for the future. Oh, okay, I think that's enough of me droning on now. I've taken up way too much time, and I can see there have been loads and loads of questions in the chat. So Trevor, if I can hand over to you to administer the questions, and we will try and answer together as much as possible.
Yeah, brilliant. Thanks, Louise. And again, on behalf of everyone, can I thank you for a really, really helpful presentation, particularly as you've managed to also press the buttons as well at the same time, and not having me go on slide by slide as well. So if I scan through some of the questions, and there are some common themes and trends that I'll pull together. So the first one, well, there's a group of questions around vaccinations. So Hayley and some other colleagues have asked about inclusion of school staff and the broader education workforce on a priority list for vaccines. And I've kind of give the feedback that we've heard from Mark Ansell before, that as far as he's aware, there's no current plans to include education workforce as a cohort in their own right in terms of those prioritisations. But obviously, some of your staff may well be getting vaccinated because they hit those one of those existing 9 sort of priority areas. And there's a couple of linked but subsequent questions, because Bernadette's asked a question about why some people might be having their vaccines perceived as being early, because she's had some staff that have got no underlying medical conditions from the 50 to 55 age group who have had their first vaccine. And I wonder if that's because, Louise, because of capacity being different in different areas. Could they have been brought forward because there's capacity to work down that priority list?
Yeah, there's no specific timeline for these cohorts of individuals. So it's up to each area and how well the CCG and other providers are delivering that vaccine. It's up to them to kind of move on to the next cohort. So there's an overall schedule or overall ambition by the government to have everybody offered their first vaccination, every adult, by July. But within each borough, how they actually move down those priority cohort lists is up to them to move on to the next section in that list. So it's possible that they've just been highly efficient, got through people much quicker, and have moved on to the next cohort a bit earlier than us locally, or we locally have managed to catch up and done that next cohort.
Thank you, Louise. And there's a linked question from Emily as well, who's made the comment, if I can just find it here, sorry, that in Waltham Forest, some of their workforce are on a waiting list and are being called at the end of the day to take up any surplus requirements. I had heard of that happening in some areas. Louise, is that something you think we could take back to our vaccination lead in Havering?
Yeah.
To see if that's a facility we could use up. I know there's certainly agreement across Barking, Havering and Redbridge, but that's interesting to hear what Waltham Forest are doing.
Yeah, we'll take that back to our vaccination lead.
And linked to vaccinations, there's another question. I think that might have also been from Emily about if people had had the vaccine, would they show a positive test?
No, no, they wouldn't. It's a different form. So the recommendation is definitely that even if you've had the vaccination, you still engage in testing. So because it's like a part of the dead virus, or it's different viral fragments, it's not going to show up in the same way as a live virus would under those LFTs or PCR testing.
Thank you.
So you can still engage in testing. If you get a positive result, then you need to follow all of those procedures for a positive result is an indication. At the moment, we're still following up with confirmatory PCRs.
Thank you, Louise. There's quite a lot of communications on here, particularly from secondary colleagues, and as you described it, about the challenges of testing. There's a question from Vivian, which is about counting days in terms of what day 3 means in terms of staggering. So she's given the example, if your pupil's tested on Monday, would Wednesday or Thursday be day 3? And I know we've had this before, haven't we, with isolation, about when does the days start counting? What's your understanding of that, Louise? Although I know it's not particularly clear within the guidance.
I think all the guidance I've got so far would be count on. So it will be the next day. So the day that you do the test would be kind of like your day 0. So you count on. So if you did it on Monday, then you would be, day 1, Tuesday, day 2, Wednesday, day 3 would be Thursday.
Yeah. So likewise, your example of the Sunday night, Wednesday night would meet that requirement, wouldn't it? You
It
gave
would.
earlier. There's lots of other chat from Vivian's secondary colleagues about the practicalities and challenges of getting through, in some cases, thousands of pupils in that initial period. Interestingly, although the guidance does talk about from the 8th, the DFE have sent me a questionnaire to fill in, which talks about any schools that we consider won't be able to get through that testing in the first 2 weeks, i.e. up until the 22nd. So I think that gives us a little bit of flexibility to think about that 2-week window now, from the 8th and then the week beginning the 13th, for secondary colleagues in particular, to look at that as a window of a testing regime, ready then from the week beginning the 22nd. That's where the home testing regime, and you would expect fuller face-to-face education being able to be put in place. But whilst we've been on this group, I've emailed Nicola and Neil to suggest that maybe the HLP group might want to have a quick short meeting just to consider the testing regime, because there is a risk, isn't there, of sort of a completely different approach being taken by different schools. And I recognise schools are different sizes, so it means that their regimes might be different. But at least we could have a collective understanding about where we stand there. What's your view of that, Louise? Because I know we were pleased to see this move, towards home testing, but there is going to be a challenge, isn't there, in that kind of first couple of weeks back, it looks like, for secondaries in particular.
Yeah, definitely. I think one thing to bear in mind there is, as soon as they've had one negative test, just one negative test, the first one, although they're asking for 3 tests in those first couple of weeks, that first negative test kind of releases them to come into the school environment. So the staggering could be in terms of prioritizing the years 10 to 13. So on that first day, whatever years you can get through in that first day, to have that test, that very first test, and then to be within the school environment as soon as possible. It doesn't have to be, they have to have 3 negative results in order to be coming into the school environment. It's just 1 negative result. But I think it is going to be really challenging. I think there's lots of discussion that we can have in terms of helping support the best methodology, the best approach to get those number of pupils through. We know this is a really, really tough task. And I don't think it's a one size fits all approach. I think it needs to be far more flexible than that, of what suits your school. So yeah, I think an HLP meeting would be really helpful.
Thank you, Louise. There's your slides there about the face coverings and the face screens have prompted a couple of questions and comments that have come through, particularly about I think Steve has commented about a hearing impaired option, and I've seen these, haven't you? Sort of with it with a clear perspex or something built in within the face mask. I wonder whether some of that's, Louise, we could probably take away and consider, because I think Matt's also said about maybe the local authority could support that. So
Yeah.
I'll take that away and discuss it with our PPE lead to see whether that's something in particular we could support and introduce, particularly with this change in the guidance. What's your thoughts on that, Louise?
Well, I have seen different types of perspex masks which actually cover the nose and the mouth as well. Whether we could look into supporting that in some way of the purchase of those particular masks for those who might need it. It all depends on budgets at the end, but I know that there's different options and approaches.
Thank you. Well, I'm just trying to scan through. Darren asked a question again, particularly for secondary colleagues, about the changing policy about the wearing of face coverings in classrooms or other suitable settings. And I responded back, but just for colleagues' benefit, so that haven't seen that yet, it isn't, as far as I can see, a legal requirement. It is a recommendation
That's
within the
right.
guidance, and no child should be refused sort of face-to-face education. But for those of you that joined the call yesterday,